Okay, so the first question is to define the pathophysiology of anemia, provide the lab values that resulted in anemia. So, what I like to think about is when I think about anemia is I know automatically, I think what comes to my mind is that there's a decrease in hematocrit, right? And there's a decrease in hemoglobin. So when I think of those things as like my go-tos, I have to think about, well, why, right? Because she wants to know why does that happen? So if we think about the ways in which hematocrit and hemoglobin can decrease, now normal hematocrit is typically between 30, 35 to 45, but for men it's slightly higher, so it's like 42 to 52-ish. And for women, it's like 35 to 45%. It's always lower for women because women menstruate, so we bleed more, so we don't have as high of hematocrit. Same thing with hemoglobin. Hemoglobin's about 12 to 16 for a female, whereas for a male, it's 14 to 18. They're always going to be slightly higher. But mentioning bleeding, right, or menstruating is what women do. One of the reasons why people can become anemic is through blood loss, right? That's one way in which we can decrease those values and go into anemia. But anemia simply means there's any sort of decrease or inadequacy in the red blood cell production. So that could be due to bone marrow, being, let's just say, bone marrow being suppressed, that can cause someone to be anemic, right? She also said that the deficiency is also due to this hemisynthesis, which is needed for red blood cell synthesis, and it could also be due to red blood cell loss, due to external blood loss, like we said, bleeding, or a decrease in the number of circulating erythrocytes, which also just means red blood cells, like if they are being destroyed, which would be an example of um, hemolytic anemia. So I always think the best way to think about anemia is, like I said, we're talking about a decrease in red blood cell production through some sort of mechanism. And we've learned that there's hypoproliferative, so there's a decrease in the production of red blood cells just from, it could be different disorders that could be affecting the bone marrow because, as she said, it could be due to bone marrow damage. So an example could be aplastic anemia, and one way that is caused is through certain medications, like any of those viral medications that you give to patients who have like HIV. Those can actually put you at risk for aplastic anemia because they affect the bone marrow. And there's also hemolytic, which means they could be destroyed somehow. So in sickle cell disease, we see a destruction of red blood cells, and that's because they're having this sickling shape, because they're having so much vaso-occlusion, right, and so much lack of blood flow that the red blood cells aren't looking the way they're supposed to. But like I said, other things that Dr. Remy wanted us to know was the patho, which we discussed already. She also mentioned that a nursing diagnosis specific to anemia would be activity intolerance related to anemia. Why would a patient who has anemia have a nursing diagnosis of activity intolerance? Does anybody know why?
They get tired easily because of the anemia. They're not having enough oxygen in their blood.
Exactly, right? They don't have enough oxygen because they don't have enough circulating red blood cells. And we know that red blood cells carry oxygen. They carry oxygen to our tissues, they carry oxygen everywhere. So if we have a decrease in circulating RBCs or erythrocytes, we have fatigue. And that fatigue can be so bad that they have activity intolerance. They're not able to perform activities maybe at the pace that they like or at the speed that they like because they become easily fatigued. And that's because they're becoming hypoxic as a result of having a low circulating RBCs. And in addition to that, they'll have a lower hemoglobin and hematocrit. And hemoglobin is what carries our oxygen. So that also results in them looking pale, right, feeling fatigued, and all of the other manifestations that they have, right? So cardiac wise, they're going to have a lower blood pressure and a weaker pulse. Um, and a higher heart rate as compensatory mechanism for the lower blood pressure. Their respiratory rate's going to be more increased. Um, they're going to have dyspnea and shortness of breath because they have a low SpO2 as a result of, like I said, poor circulating RBCs, not enough of them, means not enough oxygen. They're going to be dizzy neurologically because they just don't have enough oxygen carrying around. Um, Fatigued because of the lack of oxygen in terms of musculoskeletal. That's why they have that activity intolerance. Their skin's going to be more pale. Their nails are going to be more thick and their hair is going to be more brittle just as a result of all of that lack of oxygen. And they could even have jaundice. And that's because if we're talking about hemolytic anemia, if we're talking about destruction of the red blood cells as a result, right? When red blood cells break, they release bilirubin, and that bilirubin is going to start building up because of the destruction is going to exceed the body's ability to excrete it, and they're going to become yellow. Their mucous membranes are also going to change, right? So their tongue is going to change. They're going to have something called angular chelosis. I'm going to say it like that, which is cracking at the sides of the mouth, and their conjunctiva in the eyes is going to be pale. So think about all those things. All relates to what happens when someone's anemic. Other lab values to consider that Dr. Remy mentioned is the MVC, which is the size of the cells, right? So there's different size like normocytic, microcytic, macrocytic, megaloblastic. There's MCH and MCH, which is basically the amount of hemoglobin in the cells, and that determines the color. Because remember, hemoglobin carries oxygen. If the hemoglobin being low is also affecting how our skin looks, meaning we're becoming more pale in color, it's also going to make the red blood cells look more pale. So they could look more hypochromic. And as Dr. Remy said, right, hypochromic um, and microcytic is very characteristic of iron deficiency anemia, which just makes sense because one, the poor circulating oxygen, and two, hemoglobin needs iron. So if there's also a deficiency of iron, that's going to further cause the problem of anemia, which is the hypoxia, right? So just remember, we're talking about if we have not enough RBCs, we don't have enough oxygenation in the tissue, so we have hypoxia. Okay. Is there anything else anybody else would like to add for this question? Okay. So, um, the next question has to do with identifying the lab values that results in someone who has aplastic anemia. So just to backtrack, right? When we're talking about anemia and we're talking about diagnostic tests, we talked about hemoglobin and hematocrit. We talked about the size of the cells, right? So we talked about the MCV, right? We talked about the need for having MCHC to look at the actual color um of the cells based on that hemoglobin that's in the cells. Other things, right? We're going to look at the RBC count, which Dr. Remy mentioned for males is like 4.5 to 5, and for females it's, let me just double check. It's 4.4 to 5. Yeah. Okay. I don't know why I couldn't think of it for a second. But, right, we need to look at that RBC because we expect with someone who has anemia generally to have lower RBC levels. Right, yes, we're going to look at iron, vitamin B12, folate to determine the cause of anemia, as we've determined there's other causes. Um, we may be looking at bone marrow aspiration as well. And we could have a haptoglobin test, which is just a type of hemoglobin, and erythropoietin levels, because erythropoietin is what makes RBC. So that's also going to tell us where is the origin of this anemia, right? So we look at these things already to characterize regular anemia. But aplastic anemia is not only the problem with the RBCs, it's also a problem with suppressing the bone marrow entirely. So that means there's also a decrease in WBCs and there's also a decrease in platelets. So for this specific question, I want you to think they have basically pantocytopenia, right? They have a decrease in everything. White blood cells, red blood cells, platelets. So we have to think about, right? Not only do we have to worry about activity intolerance for someone who has aplastic anemia, we also have to put them on neutropenic precautions because they're at risk for infections because of a decrease in white blood cell count as well, and they're at risk for bleeding because of decreased platelets. So we're gonna look at all of those things we said before, as Dr. Remy said, like a reticulocyte count, which helps to see because reticulocyte is like the preformed red blood cells before it becomes red blood cells. So we look at that to see what's going on with the circulating red blood cell count. The MCV, which we said is to see the size of the cells, which we know are going to be smaller. And we're going to want to get a CBC because not only are we looking at that hemoglobin and hematocrit, as well as those RBC levels, but we want to see the neutrophil count and we want to see the platelet count. And we need to see those because, as I said, they're at risk um, for neutropenic precautions and they're going to need reverse isolation. And they're also at risk for bleeding. So I want you to think of all that. So we're going to do the diagnostic test that we normally do for anemia, but in addition to that, we're going to get a CBC because we need to look at white blood cell count as well as platelets. Is there anything anybody else wants to add? I just want to point out that the levels, I don't know if she's going to specifically ask about the levels, but that the reticulocyte count for plastic anemia should be less than 60,000. MCV, which is like we said, the size of the cells should be like 82 to 98, but it is going to be less than 82 because we're talking about anemia. And of course, for our RBCs, WBCs, platelets, hemoglobin, hematocrit, we expect all of them to be decreased, especially that neutrophil count. So just keep that in mind. Um, and yeah, I don't think there's anything else to add for that. Um, and yeah, it's still a type of anemia. So we're still having fatigue, right? Pallor. But they're also at increased risk for infection, hemorrhage, and so we could be seeing on them ecchymosis and petechiae, meaning they could be bleeding, right? Um, and yeah, okay. Um, so the next question is to define the pathophysiology and identify clinical manifestations of thrombocytopenia and no platelet lab values. So, what is the normal platelet count value?
150 to 350.
Yeah, sometimes they say 150 to 400, but it doesn't matter if we don't know the higher number because we're talking about thrombocytopenia. And anytime we see the word penia at the end, we're talking about something's going to decrease. So thrombocytopenia means the platelets are decreasing. So we expect for these patients to have a platelet count of less than 150,000. So thrombocytopenia, as I said, it means diminished platelets. And instances where we could see that, right, is if in the case if someone's bleeding, right, their platelet count might decrease. Um, so we need to watch out for that. And sometimes doctors could order a platelet transfusion if their platelets are really, really low, right? They could even have a blood transfusion of packed RBCs if they're bleeding a lot too, because we're going to look at all of the lab values. But specifically, if we're talking about a patient who needs more platelets, it would make sense to give them a transfusion of platelets because that's going to help them potentially elevate their platelet level. But sometimes, due to circumstances, we need to include like packed RBCs because there's more things in there to help increase other levels of the blood besides just platelets. But it's definitely good to know that in a case of someone, let's just say, who's bleeding, the doctor may order platelets and, you know, packed RBCs because that's specifically what Dr. Remy mentioned. We also need to promote safety and bleeding precautions. So, what are some ways that we can prevent our patient from bleeding? Like, what can we educate them on? Yeah, we could educate them on their diet, right? Certain things to eat, certain things not to eat, right? So, for example, if they also wanted to get like um a stool test to test for blood. Certain foods they're not going to be able to eat, like red meats, because that's also going to make it look like there's blood in the stool and it could affect the levels. Um, but what are some like bleeding precautions? Like, should they be using regular razors to shave?
Electrical razors, soft bristle toothbrush.
Mhm.
Mm-hmm. Anything else?
And not do like heavy activities, like maybe swimming or things that are like less, it's, lower risk of falling or injuring themselves and get bruised up and start bleeding.
Mm-hmm.
Or
Yeah.
aggressive activities, exercise activities.
Yeah. Sir, they can't have contact sports, right? Because
Yeah,
that
that's what I meant. Contact sports, yes.
I figured that's what you meant. I was getting that response in my mind. That's what came to my mind when you said that. Yeah, right? Because contact sports would put them at risk for bleeding, but something like swimming wouldn't. Electrical razors are better than regular razors for, bleeding purposes. We should also, as Dr. Remy said, there should be clear pathways to anywhere they want to go, including the bathrooms, and we should assist them going to the bathroom because remember, these patients are at risk for bleeding, and if they fall, they can bruise and, bleed internally in places, and no, we don't want that. We also want them, she said, to have cough suppressants so they don't cough too much, probably so that, even like if they have something in their throat, right? We don't want them to cough too hard where they sort of cause bleeding or tears. As well as if they try to push really hard, they can cause rectal bleeding, right? So we would want to give them something like Coley so it's a little softer, a little easier for them to go to the bathroom so you don't have to worry about rectal bleeding, right? Because they're at risk to bleed heavily when they do bleed. Um, we already said that for skin assessment, we should be looking for petechiae and echymosis. Um, there also could be easily bruised. We should look out for that. That could indicate, hey, this patient has thrombocytopenia, right? Or that they're bleeding. We should look out for hematuria and melena, right? For blood in the stool, that's what melena means, or hematuria, blood in the urine. Um, Mucous membranes, right? If they use like a hard toothbrush or even like they floss too hard, they could have bleeding in the gums and they can even have an enlarged spleen. So we want to look out for all these, especially I think the main point is that they're at risk for bleeding. So we need to monitor for signs and symptoms of bleeding and take actions to prevent the risk of bleeding. And we should educate them to avoid aspirin because aspirin and other NSAIDs are going to increase the risk of bleeding, so they shouldn't be taking those either. Okay. The next question is to identify clinical manifestations of a client with the diagnosis of thrombocytopenia and provide clinical management and know the medications that interfere with thrombocytopenia include corticosteroids. So we already said no NSAIDs, right? No aspirin, no heparin, no warfarin, because all of those are going to increase the bleeding risk, as well as no corticosteroids. And why do we want to avoid corticosteroids? What's the reason? Well, steroids, besides, helping with reducing inflammation in our respiratory patients, right? They also affect the coagulation cascade, so they can actually put you at risk for bleeding. That's why Professor Remy specifically emphasized that for these medications, you also taper them, right? You're not going to just abruptly stop them. You're going to decrease the dose over time until eventually they don't need it anymore because it can cause bleeding. Other reasons why you also want to taper corticosteroids is that they can cause urinary retention and they could even increase sugar levels. But the main point in terms of thrombocytopenia is that they can cause bleeding. So we need to be very careful with corticosteroids and we need to taper them off if we're going to stop them. Okay. The next question is provide the highest priority nursing intervention of a client with a diagnosis of a GI bleed and review liver cirrhosis. So for this question, I have that Dr. Remy said when you have liver cirrhosis, you are at a high risk for bleeding, and that means they could have a GI bleed. So if they do, we want to give them packed red blood cells. Does anybody have anything else they want to add? Okay. I don't have anything, like I said, else to specifically add on for this question. I'm not the most keen when it comes into like knowing liver cirrhosis, but um I guess the way I would think about it is if, the liver's failing, it's also going to affect other areas of the body, and it's also going to probably have some sort of effect on the coagulation and our body's ability to stop bleeding. So, if they have a GI bleed, we want to give packed red blood cells. That's what I have her um in her for her notes. If you have anything else, you're more than welcome to share, but that's all I have. Okay. So, the next question is to identify the predisposing factors of sickle cell disease, clinical manifestation, and nursing management. So we already talked about sickle cell being an example of hemolytic anemia, right? And it results from this defective hemoglobin molecule. And that defective hemoglobin molecule is causing this S-shaped hemoglobin, which means it's really poorly oxygenated, which causes very severe pain. And it mainly affects African Americans. Um, and hemoglobin S, right? S being it looks more like crescent shaped, and they call it S because it's like sickled, right? It's sickled due to all of this lack of oxygen in the blood and lack of oxygen in the cells. And if the hemoglobin is specifically a factor, remember we said hemoglobin has iron, iron carries oxygen. So if the hemoglobin isn't where it's supposed to be in terms of its shape, meaning it can't do what it needs to do, they are oxygen poor. And that for these patients causes severe joint pain, which also means that they have vaso-occlusive crises. So they basically having lots of periods where they're having intense pain due to not having enough adequate oxygenation to different tissues. They also have it as a result, as Dr. Remy says, enlarged spleen, and they can have an autosplenectomy where their spleen detaches um, from itself. And the problem with that is the spleen is really important because it's the RBC graveyard, right? So when the red blood cells die, they go there to be recycled. And if we don't have that, we don't have that function either. They're also at risk for infections. So we need to be mindful of that and pressure injuries because of the lack of perfusion. So imagine this, right? Their skin, right, is a barrier and a protection against infections. But now their skin and other vital organs and systems in their body aren't getting adequately perfused the way they should be. So that's putting them at risk for their infections. And the treatment priority, it always goes like this: hydration first, oxygenation, and pain. That's the order that you always want to do it. And that's because, yes, they're deprived from oxygen. And yes, if we're thinking about ABCs, oxygen would come first. But we need to hydrate the cells first because we cannot have dehydration. We need the cells to swell up a little bit so they have a better oxygen carrying capacity. If we give them oxygen and the cells aren't big enough to take it, well, they're not going to take the oxygen. It's not going to help them as much as if we hydrate them first, and then we do oxygen, and then we do pain management. Yes, we want to give them folic acid and vitamins, and we can give them a blood transfusion, but it has to be hydration first, oxygenation, and then pain. Okay. And I just want to also talk about, which I don't think Dr. Remy specifically hit in this question, is the factors that precipitate a sickle cell crisis. So anything that causes physical stress onto the body is going to precipitate a sickle cell crisis. Anything that's stressful, right? Actual physical stress can precipitate a sickle cell crisis. Dehydration is another reason for why they can go into a sickle cell crisis. So they always need to be hydrated. We tell them maintain their hydration status, right? They have if they have anesthesia because that depresses things in their body, that can cause a sickle cell crisis. Any sort of temperature changes, especially going from really hot to really cold environments, cold to hot, vice versa, and just being in, really too extreme temperature differences, no, they cannot do that. That's going to hurt them even more. High altitudes, right? Because when also think about it, if you're going up higher into a mountain, you're you're not really going to be able to get the oxygen that you need. It's actually going to start to decrease the higher you get up. That's also going to hurt them. Alcohols, infection, and hypoxia, all of those precipitate a sickle cell crisis. And remember, we said this is vaso-occlusive. That's the reason, right? It's causing lack of perfusion. They're having hypoxia, but it's still a type of anemia. But with this, they have severe pain. They could have a fever, especially if they have an infection. They could have jaundice, because like I said, this is a hemolytic anemia. So as a result, hemolytic means RBCs are being destroyed, jaundice, right? Um, Organ failure, like we talked about, an enlarged spleen or an autosplenectomy. It could even affect the liver, the heart, the kidney, the brain. They're very susceptible to infections. And the vaso-occlusive pain or the vaso-occlusion can be so bad they can go into cardiac arrest. And she said specifically for males, they can have priapism, which is basically a persistent penile erection. So those are just how I want you to understand like anemia, especially sickle cell anemia, right? We're talking about hemolytic, we're talking about a lot of pain. We're talking about this patient not having enough oxygen in their body. And because of how severe it is, any sort of distress on the body and changes can cause a sickle cell crisis, which is really, really bad. So I just wanted to point that out. And as I said, for patient education, it's going to be to avoid all those triggers, right? To avoid stress, avoid dehydration, avoid alcohol, avoid smoking, avoid extreme temperature changes, avoid high altitudes, right? Um, Things like that. Okay. The next question is to assess a client with a diagnosis of immune thrombocytopenia purpura, let's say it like that. Provide the clinical manifestations of ITP and medications that alter platelet function. So it's basically like just similar to thrombocytopenia. So obviously we're going to look for signs and symptoms of bleeding, like we talked about petechiae, ecchymosis, hematuria, things like that. Um, and for medications, as we said already, right, no NSAIDs, no clopidogrel, no aspirin, no corticosteroids, and no sulfonamides. So anything that starts with sulfa would be a drug that can also alter platelet function and cause bleeding, so we don't want that. Um, and yeah, is there anything else anybody wants to add to this question? Okay. But like I said, this is a type of thrombocytopenia. So all of our nursing interventions are teetered towards looking for manifestations of bleeding, right? Which include things like we said, ecchymosis, petechiae, purpura, or like red spots, bleeding in the gums, right? Epistaxis or bleeding in the nose. Anything that has to do with bleeding, and they will have hypotension as a result of that too, if they are bleeding. Um, and yeah, okay. So the next question is to identify patient at risk for vitamin K deficiency, signs and symptoms, and nursing treatment. So, when we're talking about vitamin K, right, vitamin K affects clotting. So when we have good vitamin K, we're able to clot and stop bleeding. If we don't have enough vitamin K, we are at risk for bleeding. So, the issue is that when we're at risk for bleeding, right, we already see all the signs and symptoms that we can have and what it can do to the patient's body, right? But we also need to recognize the populations that are at risk. The textbook specifically said that one population that is at risk is anybody who is malnourished. If they don't have enough vitamins and are not able to intake enough vitamins, they could have vitamin K deficiency. Some antibiotics can affect the body's ability to produce vitamin K, and as a result, that can also affect vitamin K levels. And specifically, Dr. Remy said that for the patient at risk, it would be someone who has liver disease. Anybody who has liver disease is at risk for vitamin K deficiency. So you could associate vitamin K deficiency with liver disease, especially if we're looking for like an answer choice that talks about which, patient would be at most risk. I would say pick the one that said liver disease, as she mentioned that. Um, and also, how will we know if they have vitamin K deficiency? Well, we're going to look at things like their INR and PT, because if these are, really high, that means vitamin K is not doing what it needs to do to clot and prevent bleeding. Is there anything else anyone wants to add? Okay. But yeah, I would associate, if you see a question, vitamin K deficiency and liver disease, because she specifically mentioned that. And that's something that helps me with her quizzes. If I notice there's something that she specifically says, I tend to go for it, because 99% of the time it's usually correct, unless I find something somewhere else that says otherwise. Uh, but okay. The next one is to provide nursing care of a client receiving a blood transfusion. Be familiar with the clinical manifestations of a blood transfusion reaction and provide management pre, during, and post for a blood transfusion. So I'm pretty sure this is going to be a type of question that relates to if someone's having a blood transfusion reaction, what do we do? So what is our first priority as a nurse when we recognize someone's having a blood transfusion reaction?
Stop the transfusion.
Exactly. Our first priority is to stop the transfusion. We do not want to keep something going that's going to react with the patient, because one, that could result in death. We don't know why they're having the reaction. We just know that their body is not reacting well to this blood. So it could be the blood issue, it could be anything, but we need to stop it first. Then we're going to assess our patient, right? Because our patient is our priority. We stop the infusion, assess them through getting vitals and asking them about their symptoms. Like, are they having back pain, fever, restlessness? Are they feeling itchy? Are they having crackles, and pulmonary edema? They're not going to tell us that, but we are going to assess that. Um, Through auscultation, they could have a visible rash, right, or complain of a rash is developing. They could feel nauseous and want to vomit. Um, Shortness of breath. They could even have blood in the urine or have chills. Anything like that. They're like, "Oh, nurse, I have back pain." Oh, they're showing that they're having a fever. They're having chills. And that's one of the reasons why when a patient has a blood transfusion, we stay with them for the first 15 minutes. And that's because we want to check, are they having a transfusion reaction? Because that's the time period in which it's most likely. That's why we're assessing their vital signs very carefully and we're staying with them. We also, if we notice that they're having a blood transfusion reaction, so we stop the transfusion, we assess the patient with vitals and looking at their symptoms. Then we're going to maintain a normal saline infusion, right, to try to drain out everything that's going on there. With a new tubing, right? We're not going to use the same tubing, because we're going to take the tubing of the blood still connected and bring it back to the blood bank so they can analyze it to see what went wrong, and we're going to notify a doctor. We should also have epinephrine on standby, right? Especially if they're having shortness of breath and their throat is closing. Yeah, they're gonna need that. And remember, we cannot have any other fluid running with blood other than normal saline, and that's because it can cause crystallization of the blood, it can cause the blood to clot. So we do not give any other fluid um with a blood transfusion other than normal saline. So, just to quickly remind us of pre-transfusion responsibilities, right? We're thinking about getting vitals. We're thinking about making sure that there's an IV site, right? Especially of an 18 to 20-inch gauge, because we need something bigger. We need something bigger so that the blood can go through, because the blood is thick, right? We want to also check their CBCs, right? The hematocrit and hemoglobin, right? To also make sure this seems okay, right? They should have a lower hemoglobin hematocrit. That should be the reason why they're getting it. As well as we should be looking at the type and screen. we need to compare, make sure that the blood and the patient's blood type are compatible, and that we need to have two nurses there before we give the transfusion to identify the patient and identify the blood. So we look at the expiration, the numbers, the prescription, and make sure there's informed consent. But we do that with two nurses, right? We're going to examine the blood bag, look at the tags, make sure everything looks compatible. There's no like discoloration or bubbles or anything that looks abnormal. If the patient's temperature prior to the transfusion is elevated, we want to notify the doctor we don't want to administer the transfusion. Um, and if the blood, let's just say, was out for an hour, we don't want to give it. You usually want to give blood that came from the lab within like 30 minutes. So we do not want to give blood if it's been out for too long. That's why this is like a semi-quick procedure, right? You need to have another nurse readily available and has to be done pretty quickly to get the blood up and running. And how long do we administer the blood for? How long do we do that?
3 hours.
4. We do not administer it longer than 4. It's going to be within 4 hours, no more than that. It could be 3, it could go faster, but no more than 4. Also, if it just goes longer, it puts them at risk for like overload. And we also want to make sure that we have appropriate tubing. That's typically the Y tubing. We already said we use normal saline. And like I said, we stay with the patient during the first 15 minutes because that's when the most severe reaction can occur. And we already talked about what we do when that happens. So I'm not going to really get too much into that. But okay. So the next thing is to provide nursing management of a client with iron deficiency. So, what is a medication that we can give to someone who has iron deficiency?
Ferrous sulfate.
Yes, right? Because that's iron. We can give them iron supplements. Um, they could increase their food intake of things like leafy green vegetables, right? Um, calf liver, chicken meats, things like that, beans, dried raisins, all of that stuff would have high iron levels. And what vitamin increases the absorption of iron?
Vitamin C.
Yes, so that's things like orange juice or anything that's a citrus fruit. Also, we can give something that Dr. Remy specifically mentioned. It was iron dextrin, which can be given IM or IV. And if we give it IM, there needs to be the Z-track method. So other things when it comes to iron is that it's not taken with food. It's either taken 1 hour before or 2 hours after a meal. No milk or no antacids can be taken with it because it's going to decrease the absorption. If it's taken in a liquid form, it needs to be given through a straw. That way it prevents staining on the teeth. Um, we already talked about different ways of like different foods that increase iron intake. So meat, fish, poultry, beans, nuts, seeds, all that stuff. The green leafy vegetables, vitamin C, like we said, helps enhance the absorption. And we also want them to increase their fiber intake because iron can cause constipation. But remember that dark stools and dark urine while taking ferrous sulfate is okay. That is expected when taking this medication. That's not alarming. We don't think they're bleeding. That's okay. I just wanted to put that in mind. Okay. The next question is to provide the pathophysiology, clinical manifestation, nursing assessment, and nursing management of Hodgkin lymphoma. It's an NGN question and no pharmacological effect of megestrol. So, does anybody remember what Dr. Remy said about megestrol? Or what's its intended purposes?
It's used to increase their appetite.
Yes, and that's because this is a cancer patient, and they are cachexic, which means they're having muscle wasting or they're having very, very weak muscles, and they have failure to thrive, meaning they don't really have much of an appetite. So they have weak muscles, no appetite. We give them Megastrol to increase their appetite so that they eat more and we can reduce those symptoms. Management, according to Dr. Remy, she was saying, when we want to give them foods, we should focus on their culture in terms of they should be eating culturally appropriate foods or foods that they want to eat, but making sure that it also fits into the guidelines of such as not too greasy or not too spicy. Um, these patients, being mindful that these patients aren't going to have as much energy, they're going to be really tired, that they need lots of IV fluids. That they're going to also have increased Reed-Sternberg cells, because that's the difference between Hodgkin lymphoma and non-Hodgkin lymphoma. One of them being that Hodgkin has Reed-Sternberg cells while the other one doesn't. And the problem with Hodgkin is because it's a progressive cancer, it's based on how much this disease progresses into the lymph nodes. It can become more necrotic, and the lymph nodes can start to basically undergo fibrinolysis, and they kind of start clotting. They almost start breaking down and becoming these really tough nodes and not the way they're supposed to be. So we have to be really mindful of that, right? And that maybe palliative care could be an option for these patients depending on the progression. Another thing is how to do the lymph node assessment. Um, such as starting with preauricular or going from the front of the ear, then going to postauricular behind the ear, and then the occipital, the back of the head, and then tonsillar, submandibular, submental, superficial cervical, posterior cervical, deep cervical chain, supraclavicular, and then sternomastoid. Um, I don't know if she's gonna specifically ask that, but I would just know where you start, because you could say like, oh, do a lymph node assessment starting with preauricular. That would make sense. And other symptoms that relate to this, because remember, this is a malignancy of the lymph nodes and the lymph node tissues, is that besides Hodgkin's lymphoma having painless lymph node enlargement, they also have besides them having Reed-Sternberg cells, they also have painless lymph node enlargement, which is different than non-Hodgkin's lymphoma, because the symptom-wise, they have very similar symptoms, except for the idea of the cells, and that with Hodgkin's, they have painless lymph node enlargement. Um, and both Hodgkin's and non-Hodgkin's have B symptoms, so they both will experience things like fevers and sweats and weight loss, because remember, they are cachexic and things like that. But I just wanted to point that out there, that those are one of the main differences, is that the cells and the painless lymph node enlargement is specific to Hodgkin's, besides all the other stuff that we spoke about. The next thing is the next question is assess and provide clinical manifestation of multiple myeloma. So multiple myeloma is basically a tumor. It's a tumor of the bones, essentially. It's a neoplastic proliferation of all of these well-differentiated immunoglobulin producing cells, which basically means there's an increase in all these plasma cells, and there's a problem with them, which is basically causing a lot of bone pain, because myelinoma means relating to the bone. So there's tumors of the bone, okay? And that is going to cause them to have, which is characteristic for this is how I would know it. Multiple myeloma relates to bone pain and bone problems. So they can have osteopenia or severe bone pain, bone lesions. They're also going to have hypercalcemia. Why? Because these are tumors of the bones. They're affecting the bone's ability to grow. And as a result, they're having osteoclastic activity, meaning the bones are breaking down. When the bones break down, they release calcium. Higher the calcium levels are, the more the bone breaks down. So they're going to have hypercalcemia, osteopenia. They're going to have bone lesions because it is affecting the bones, right? It also affects your your blood cells. That's the word I was looking for. So they're at risk for anemia. Also, they're at risk for renal failure, as well as an increased ESR. So, right, we have problems with the kidneys, we have bone problems, and we have hypercalcemia as a result of the bones breaking down, which also puts them at risk for fractures. So management includes, right, making sure we monitor electrolytes, right, especially those calcium levels, looking at those renal values like BUN and creatinine, right, making sure that we also assess CBCs. Why? Because they're at risk also for anemia. We also want to look at their ESR level because it's going to be increased. Now, this level basically just relates to like, um, I, I think it also relates to inflammation. Someone can correct me if I'm wrong. I believe this is one of those also inflammatory markers. Someone can correct me. But we also want to put them through an MRI and a CAT scan because we want to see if they have bone lesions. So just think about the manifestations. If you know the manifestations, you know the management, right? They're at bone pain and bone lesions. We want to look at that to see if they're there, right? They have hypercalcemia. Oh, we got to look at electrolytes. Oh, they could have renal failure. We need to look at BUN and creatinine levels. Oh, they're at risk for anemia and an elevated ESR, so we need to do a CBC. Okay. So, the next question is provide patient education of a client with Hodgkin lymphoma to reduce secondary malignancies. Now, all I have for this question is that Dr. Remy mentioned that um, tell the patient if they have problems with their eyes. So, if their eyes are becoming more round and they're starting to see halos around the eyes, they need to avoid direct sunlight. They need to avoid smoking and they need to limit and reduce their alcohol intake. So, we could think Hodgkin's lymphoma can affect their eyes. And as a result of that, if they're having halos, they need to avoid, sunlight, like we said, smoking and alcohol. Is there anything else anybody wants to add to this question? Okay. So the next question is to provide patient education of a client with non-Hodgkin lymphoma and undergoing treatment as on an outpatient basis. So, for someone who has non-Hodgkin lymphoma, we talked about a little bit of the difference between that and Hodgkin's, right? The Reed-Sternberg cells and the painless lymph node enlargement in Hodgkin. But in non-Hodgkin, they're gonna have pain in the lymph nodes, but they also have both of them have those B symptoms, right? The fever, the sweats, the weight loss. But these particular patients are at a high risk for pancytopenia. So they need to be discharged on neutropenic precautions. So what are our neutropenic precautions? Well, we want them to avoid sick people and crowds, right? Because neutropenia means that they have a decreased neutrophil count, which means they're at risk for infections. So we want them to avoid sick people and crowds, right? No fresh flowers in the room, no raw fruits and vegetables. They should only have cooked fruits or any sort of food that they're eating. Anything should be cooked, and they should wash their hands frequently. Okay. We already talked about neutropenia precautions, someone who has leukemia, because this question number 5 is providing nursing measures for a client with leukemia and neutropenia. Well, leukemia also affects all of your complete blood cell count, so it affects your red blood cells, your white blood cells, things like that. So they're at risk for neutropenia. So same neutropenic precautions as we said before. Other things include make sure they have good hygiene, they have good oral care, that they don't go near gardens and cleaning bird cages and litter boxes. Because there's something in litter boxes like toxoplasmosis, something like that, and they can basically get infections from litter boxes. And no gardens because it could be very dirty. Um, and things like that. And making sure any food that we said already, if they have that, food-wise, it needs to be cooked properly. We can't be giving them raw food because that could have a bunch of bacteria on it that they should not be exposed to. Okay. The next question is to provide the pathophysiology of type 1 diabetes. Now, does anybody know what the difference is between type 1 and type 2 diabetes?
For type 1, early onset um, age at a younger age, and type 2, you could get it as older age, above 30 years old. Um, uh, Type 1 uh, has destructions of beta cells, so they cannot release or produce insulin. And whereas type 1, they still could produce insulin, but they're just insulin resistant, but they could still produce insulin.
Yeah, exactly, right? So type 1 is usually something that's autoimmune, right? They were typically born with this. Most of these people, or at least people I've met who've had type 1 diabetes, have seen this at such a young age. They've had this very, very young. Like they could be 5 years old and be told, because it's an autoimmune problem, right? There's something that they were born with that was going to trigger them to have type 1 diabetes. And as a result of,
Yeah, is this genetic predisposition or no?
yeah, it could be familial. Yeah, it has a family and genetic predisposition, right? I mean, they're not like, oh my God, when they're born, they have it, but they can see it as like 5 years old, like very young, they could be told that they have type 1 because there's something wrong in the body, right? Because there's no insulin production or very, very little that it's not doing anything for the body. And that's why type 1 diabetics are also insulin dependent because they cannot produce insulin at all. Their body, there's something wrong with those beta cells. There's something wrong with the pancreas. They have too much islet antibodies, so there's too much fighting against insulin production. They cannot produce it on their own. It doesn't matter if they're going a procedure. It doesn't matter if these patients with type 1 didn't eat. It doesn't matter. They have to have insulin all the time because they cannot physically make insulin. So, as you've all mentioned, right, it has an abrupt onset. It does have a genetic predisposition. It's typically autoimmune, unlike type 2, which is not autoimmune. Um,
But
Also,
it's type 2 genetic predisposition also as well?
yeah, you could be at a higher risk in your family because someone who has type 2, but type 2 is normally due to lifestyle problems and obesity. So, lack of doing certain things or how you eat most likely will put you at the risk for type 2, less of a genetic predisposition than type 1 is.
So
Um,
if there's a question that says for type 2, genetic disposition, don't pick it, or you
No,
all pick it
you
for
still have a genetic link, but it's not as strong as type 1. Do you know what I mean? Like they both could have a familial history of it, but type 1 is like autoimmune. So it's like more or less, I don't know how to explain it. It's like you could be at risk for anything if someone in your family has it pretty much, right? Like most diseases, like for example, right, certain cancers, right, more than likely to get it if a family member had it. Doesn't mean you will, right? But for type 1, more than likely, right? If your family had it, right? Let's say both your parents are type 1, you're probably more than likely to have it than, type 2, because type 2 is more determined based on your um like lifestyle habits, but it would still be a risk. Like it would still put you at risk for type 2. Both of
So you will pick for both, like if this genetic predisposition, you would do it for type 1 and type 2. Would you select it? Like if you had select, all that applies. That's what I'm trying to say.
Yeah. Well, because, yeah, I would 100%. But I'm just trying to explain it unless I'm making it confusing in a way that,
No,
like,
no, I understand. Thank you.
okay, because I'm like, maybe I'm confusing. But yeah, they both have a risk from having it in your family that puts you at a risk for both type 1 and type 2. But like I said, just type 1 has a stronger genetic predisposition than type 2, but they both do. It's the same thing. But like I said, for type 1, we're talking about more of an autoimmune problem. So there's something wrong in the body that's fighting against the ability to produce insulin, which basically causes you not to have it at all. And that's because there's this production of these islet antibodies in the pancreas, which is making insulin synthesis fail. So, like I said, big difference is that you usually see these in younger age. Like I said, you could see this in like a 5-year-old because they're born right with some autoimmune problem and eventually comes out to, potentially having type 1. Like I said, you don't have to be physically born right there with it, but I know I have like a few friends who are told at 4, 5, 6 years old that they have type 1 diabetes. So you could see this at a very, very, very young age. That's why the diagnosis is typically less than 30 years of age. But anyway, yeah, like I said, it's insulin dependent, right? Risk factors we talk about, they can have a family predisposition, things like that, but they're not going to have the risk factors of obesity or having an OB history of having a baby greater than 9 pounds or having a history of gestational diabetes, right? That's not going to put you at risk for type 1. That puts you at risk for type 2. But like type 2, right, you're going to have your 3Ps, your polyuria, your polydipsia, your polyphagia. But with type 1, you typically see weight loss. And that's because they're just eating, and even though they're eating, they're really not keeping on to any of it because they have a really bad carbohydrate intolerance. Complications, just like type 2, includes delayed wound healing, neuropathy. So they have like pins and needle feeling and they can't feel sensations, especially in their feet. That's why they need to inspect their feet daily, clean them daily, and make sure they never put lotion in between their toes. Not good. That could also increase their risk for like fungal infections. Um, Retinopathy, so they can have blurry vision if they complain of that, and that's from that high sugar level. Nephropathy, so they can have problems with the kidneys, as well as they can have problems like with their heart, which is like a macrovascular complication, such as a cardiovascular disease, things like that. And because they have a blurry vision and they can have retinopathy, they need to get annual eye exams to make sure, their eyes are still okay. And for type 1, they're at risk for DKA, diabetic ketoacidosis. Whereas for type 2, they're at risk for a hyperosmolar syndrome, something like that. But you do not get DKA most likely if you're in type 2. You really only get it if you're in type 1. And that's because the body, because of no insulin production, the body has to break down fat for energy. And as a result of absent insulin synthesis, ketones and uric acid, all that starts to build up in the blood and in the urine. That's due to absent insulin synthesis. Type 2 doesn't have absent, right? They do have insulin. They just have an insulin resistance. They cannot produce insulin as they would like to do or the body should be doing, but they can. Okay. And remember, for type 1, they can only get insulin. That's it. For type 2, they get oral diabetic agents. They can get insulin, type 2, but they're typically on oral um, uh, anti-hypoglycemic drugs like metformin. Management will include things like if we're giving insulin, especially if it's rapid insulin, regardless of the patient, right? Food needs to be there really quickly. They should eat with the rapid acting. It's going to work so quick. Hemoglobin A1C is the most accurate in determining if they are treating and managing their diabetes. It tells us how well they're managing it, other than all the other ones like urine tests and fasting sugar levels. Yeah, they're good, but they only tell us what's happening right now, what's happening today. Whereas hemoglobin A1C tells us how they're doing over the course of a more prolonged period of time. And we should always change the sites if we're giving insulin to prevent lipodystrophy. So we don't want that either. So once again, like I said, type 1, abrupt, less than 30, right? It's typically an autoimmune problem and they do not create insulin. So that puts them at risk for DKA. It does have a familial and genetic predisposition, just like type 2. Now, for manifestations, it's going to be very similar, like any type of diabetes, right? Your 3Ps, weakness, visual changes, right? Numbness, tingling in the feet, right? Delayed wound healing, right? Because as a result of poor circulation due to the diabetes, as well as the higher sugar levels put you at risk for delayed wound healing. They could have recurrent infections, but type 1 has weight loss, which is something that type 2 doesn't really have. So just as a quick reminder, you could see here, type 1 risk factors include less than 30, familial and genetic predisposition, and your race and ethnicity can put you at a greater risk. Okay. So the next question is define the pathophysiology of diabetic ketoacidosis, provide clinical manifestations and nursing management, know the pharmacological action and indication of insulin. So we talked about diabetic ketoacidosis is a result of type 1 diabetes because it's due to this absence of insulin synthesis. There's no insulin production, which is causing ketones to build up in the blood and the urine, and for the body to break down fat for energy. So it's making those sugar levels go all the way to like 800. It's crazy high. For these patients, because we're talking about hyperglycemia, they have manifestations of diabetes like polyuria, polydipsia, polyphagia, nausea, vomiting. But what's a key characteristic of diabetic ketoacidosis is that they have a fruity acetone breath and they have ketones in the urine. Okay? We're going to see that. Other things is that this is a very rapid onset. If they have DKA, it's going to happen very quickly. And it's usually due to the fact that for type 1, especially, they ate and they didn't take their insulin. If they ate and they didn't take their insulin, their sugar is going to rise very, very quickly because their body has no mechanisms to control sugar levels whatsoever. Diabetic ketoacidosis is going to also affect the kidneys. So we want to check for the BUN and creatinine levels. And these patients only get continuous regular insulin. And that's because regular insulin is a short-acting insulin and it is the only insulin that works via IV. That is why we give it to patients with diabetic ketoacidosis so we can quickly lower those sugar levels. Okay. Another thing that I want to point out is, remember, this is still like a diabetic patient, so they're going to be peeing a lot. So we know that they're going to have a decreased urine-specific gravity because their urine is not concentrated, but it can affect the kidneys, so we need to look at that. So we talked about management, right? They need adequate hydration. They need regular insulin via IV, sorry. They need to have their blood sugar monitored very closely. They could also have electrolyte imbalances because remember, when you're giving insulin, right, insulin causes potassium to go back into the cells. If potassium's going back into the cells, it's going to lower circulating potassium levels, which means if the potassium level drops, they're at risk for dysrhythmias and things like that. So we must check their electrolytes and as well as auscultating their lung sounds. They're getting a lot of things via IV, so we want to make sure that they're not having fluid overload, okay? We also want to make sure we have a lot of blood work. We take urine samples because remember that DKA, ketones, we want to look at renal function and oxygen as needed. Also, we're probably going to put them NPO, especially if they're complaining of nausea and vomiting, they're going to be NPO, nothing by mouth. Okay. Now, I'm not going to get into too much with this question. It just says provide the clinical factors for diabetes, both insulin-dependent diabetes and non-insulin dependent diabetes. Now, insulin-dependent diabetes is type 1, non-insulin diabetes, non-insulin dependent diabetes mellitus would be type 2. So we already talked about the manifestations and the complications, all of that. The complications of, like we said, retinopathy, neuropathy, nephropathy, delayed wound healing, that's all the same, right? But type 1 has a risk for DKA, whereas type 2 has the other one, HHS. The things here is that for management for both type 1 and type 2, we're talking about diet, right? We need them to have a specific diet, especially one that makes sure that gets their nutritional needs. They need to exercise because exercise is going to help them lower those sugar levels. Um, and we also want to make sure that they avoid alcohol while taking insulin and they have fiber for constipation. Now, remember, our patients also need to be educated on the risk of hypoglycemia because both of them are going to get hypoglycemia if they're not taking, if they take too much of their medications or they don't eat and they take their insulin and they forget to eat and then they just need to know this, okay? Because this can happen. So for hypoglycemia, I want you to think of like your body stimulated. So they're becoming really cold, really pale, really diaphoretic. They're shaking, they're having tremors, they can become very unresponsive, they could even seize. So if they are conscious, right, we give them like a 15-gram carbohydrate, right, such as a 4 to 6 ounce of juice. We could even put 2 to 3 teaspoons of sugar and honey in it if they're conscious and have them drink it. If they're unconscious, we give them glucagon IM or dextrose 50% if they are unconscious, right? We're not going to put anything in their throat if they aren't receptive. And we want to repeat the sugar levels every 15 minutes until it goes back to normal. And hypoglycemia means a sugar level of less than 70, okay? Okay. Conduct a nursing assessment of a client with type 2 diabetes, provide nursing management and patient education, NGN. She specifically mentioned this is that if a patient says they are having rapid or unexplained weight loss, we want to measure their weight. We want to measure their blood sugar levels. We want to assess her visual issues, assess their OB history, and is there a family history of diabetes? Because as I said, type 1 and type 2 can have a family history of it. But we also want to educate them. We said lifestyle changes, weight management, especially for type 2, because obesity is usually a cause, exercise, and blood sugar monitoring. Okay, they need to do all of these things at home. I know since my grandfather has diabetes, he takes his sugar every single day. That's something that they need to do, as well as, exercising more, eating properly, watching their weight. But for type 2, right, the risk factors, which I think we should highlight, right? It's more common and it's usually a lifestyle thing. These are usually patients older than 30. They're having insulin resistance, right? They have insulin, they just can't use it as well as they like, but it still works, right? They're usually obese, these patients. Um, they have a history of hypertension. They could have a history of problems with their HDL and triglycerides. And also, if they have a history of gestational diabetes or they had babies over 9 pounds, that puts them at risk for type 2, okay? Which is different because type 1 was less than 30, abrupt onset, and it has genetic and familial predisposition. And race and ethnicity can be a risk factor for both of them. But like I said, we have to think about also type 2 does not have ketoacidosis. They're not going to go into DKA, okay? So do not pick that, okay? For the signs and symptoms, or should I say the clinical manifestations, it's going to be the same as type 1, except there's going to be no ketones in the urine, right? Not a necessity to have ketones in the urine for type 1, but it could be a finding that you'll see in type 1. You would not see that in type 2, right? But they all will have the visual changes, the tingling and numbness in the hands and the feet because they have neuropathy, right? They can have reoccurring infections, wounds that are slow to heal, things like that. All the same, okay? Except what the difference is the risk factors is the difference and what the pathophysiology is, right? Is that type 1 has no insulin and type 2 is insulin resistant. They have it, they just can't use it properly. And type 1, they don't have anything. They can't use it. That's why they're insulin dependent. They must take insulin every day in type 1, where type 2, they're going to take oral hypoglycemic agents. Sorry, anti-hypoglycemic, no, yeah, sorry, not anti. Yeah, hypoglycemic agents. They're going to take things like metformin, to help, lower their sugar levels. Okay. So we already talked about the hypoglycemia, right? What to do in an emergency. Like I said, if they're awake, 15 grams of fast-acting concentrated carbohydrate. Doesn't matter if they're type 1 or type 2, right? She also said you can give them 6 to 10 hard candies or 4 to 6 ounces of regular juice or soda. make sure we repeat the sugar every 15 minutes. And then we said unconscious, we can give the sub-Q or IM glucagon or 25 to 50 ml of 50% dextrose. The last thing that I wanted to add is that specifically Dr. Amy mentioned for the question that said assess and manage causative factors of hypoglycemia of a client with type 1 and type 2 is that type 2 has a resistance to insulin. So a cause of that could be, as I said, could be someone who eats and takes their insulin. I'm sorry, who doesn't eat and takes their insulin because that's going to lower their sugar levels, or they exercise and take insulin because that's both going to cause a really low sugar. So those would be reasons as to why they could, or in the case of type 1, it could be that they're also not eating and they take their insulin. So all of that stuff can be a reason why they can go hypoglycemia. So think, right? Insulin, no food, or insulin, no food, and exercise. All of that can cause hypoglycemia. Okay. The next question is to assess and list the complications of diabetes and provide nursing management for each. So Dr. Remy mentioned that diabetes mellitus, they have too much sugar in the blood, and that puts them at risk for pressure ulcers or what we call diabetic ulcers. They also have neuropathy leading to no feelings in the feet. So we want to inspect their feet daily with a mirror and do skin assessments and wash their feet daily. So remember, we talked about the complications, right? Delayed wound healing, neuropathy, retinopathy, nephropathy. So all of that can cause those are the complications of diabetes mellitus, right? Regardless of type 1 or type 2, they have those things. So we want to make sure they go for annual, eye exams, make sure they check their feet daily, especially because we're looking for pressure injuries and things like that, because they also can't feel sensation as well in their feet. So they might have problems in their feet and they don't realize it because they can't feel when they have things like a cut. So we need to be very, very careful with that. And remember, a complication like DKA is in type 1, whereas hyperglycemic hyperosmolar syndrome, didn't even know it was that long, HHS, that's how I know it, is for type 2. Okay? And basically, they're very similar on how you manage them. The only difference is if someone has type 2, they're not going to have the ketones. And if their sugar's really elevated, like let's just say 600, right, we're going to think hyperglycemic hyperosmolar syndrome. But we do the blood work and the urine analysis for someone who has type 1 and they have ketones, which they probably will, and when their sugar is like 600, DKA. Okay. The next question is identify the pharmacological effect of insulin on blood sugar. She said for this question, decreases blood sugar by allowing glucose to enter the cells. It promotes the storage of fat in adipose tissues. Other things, it's in one of the slides, but they could basically transport and metabolize sugar for energy. It stimulates the storage of glucose in the liver and muscle as glycogen. So remember, insulin is going to reduce sugar levels. So we're looking for answers or functions of insulin that relate to lowering the sugar levels, so bringing it back to the cells, transporting it to the cells, stimulating storage of glucose in the liver, so it's not being produced and sent out to the body. It even stops the liver from signals of releasing glucose. And it even inhibits the breakdown of stored glucose, protein, and fat. So you get the gist, right? Insulin is going to reduce sugar levels by preventing the mechanisms that would release sugar in the body. The last thing is to indicate lab values that are more conclusive diagnosis of a client with hyperglycemia, indicate clinical management to help improve hyperglycemia. So hemoglobin A1C is the most conclusive. Why? That's because hyperglycemia, as I said before, right, or someone who has diabetes mellitus, it's going to tell us how well they've been managing their diabetes or their high blood sugar over the course of 3 months. Fasting sugar levels, urine analysis, right? A casual sugar reading, they're going to tell you today how their sugar is, but that doesn't tell you how they're doing over the span of 3 months. And it does that is because the blood sugar levels, when they're elevated, the sugar molecules bind to the hemoglobin in the red blood cells. So the less you're managing it, the more sugar that's going to attach to that hemoglobin, further raising the levels and that's not good for indicating that they're managing their diabetes well. That actually indicates that it's not being managed well, especially if that hemoglobin A1C is greater than 6.5%. And yeah, that's pretty much it.